Well, my name is Barnabas, and I'm the director of St. George's, and it really is a pleasure to welcome you here and to host or co-host a community event on a very important topic about how we want to make our plans, our final plans. And it's not easy. It's a topic that most people find very uncomfortable, and you'll be hearing, I'm sure, a lot more about this, but I'm very pleased to welcome a group from St. Barnabas here, and imagine that people will come in as the program goes on. Just a personal story. I've been dealing with some of these issues with my own parents up in Rhode Island, and my father's Dutch and very practical, and so I was very happy to address these issues. My mother is very uncomfortable talking about any of these things and tries to put the topic aside. What we've found is that having the conversation several times makes it easier and easier and easier, to where it really is, it's a really life-affirming conversation to have. And I want to thank you for bringing this conversation here to St. George's, and for all of you for showing up. Thank you.
Thank you.
Thank you.
Thank you, Reverend Poppy. Hi, I'm Candace Davenport. I'm your public health nurse and health educator from the Maplewood Health Department. I just want to introduce our speaker today, who's Sarah O'Connell. She is a nurse practitioner with the Geriatric Health Center from St. Barnabas Medical Center. She's an ANCC board-certified gerontological nurse practitioner. She has experience in geriatrics, emergency, palliative care, acute care, and the outpatient setting, so she's seen it all. And talking to her very briefly while she was setting up, she's very passionate about this, and I think she'll have a very informative topic and program to share with you, so thank you. I also wanted to say that there's material on the tables for the upcoming Health Fest and other health activities. We have our upcoming flu clinic, we have our adult health clinics, and if you'd like to know more information about the File of Life, which is a packet that you can hold at home for emergency preparedness issues, please come see me after the program, and I'll provide one to you from the health department. Thank you.
All right, so my name is Sarah O'Connell. I think I've met some of you before at a previous talk, and thank you so much for being here today. I'm going to go over a couple of things, and everything that I'm going to go over today is in your packet, and I'm going to be available for questions afterwards. So anything you're thinking of, remember it so we can talk about it after we go through this. There are two different things I'm going to go over. One is an advanced directive, and the one that we're using today that we're going to go over is called 5 Wishes. And we'll go through that. And then the other form in there is called POST, which stands for Provider Orders for Life-Sustaining Treatment, or excuse me, Practitioner Orders for Life-Sustaining Treatment. So that is an actionable order set from a medical provider that would represent what a patient has expressed their wishes to be. And that's a kind of a universally recognized form specific to the state of New Jersey. And I also put an information pamphlet about the POST. But that's something that a paramedic would know what to do with, and that's something that certainly the emergency staff would know what that is, and to make sure to honor it, and just another way to protect your wishes. I wanted to ask, how many of you here today have an advanced directive already? So, I mean, I'm speaking to a well-prepared audience, but I still think I can share with you some things today that will be very helpful. You know, even the talk itself is called The Difficult Conversation. I mean, we actually struggled to come up with what to call it. And I looked at the flyer yesterday and wondered, was it clear to everyone what this talk was even about? But I like to talk about it as a conversation rather than, do you have your form checked off and signed and filed in a drawer? Because it's much more than that. You know, like she said when she introduced me, I have worked in the emergency department. Right now, I do primary care, you know, for geriatrics, but I also do consultations in the hospital, and we follow our own patients in the hospital. And what I've learned is that, you know, you and I might see each other in my office and do our homework and fill out the POST and scan it in, and then you have it with you if you go to the hospital. But if you haven't talked about it with your family, when the going gets rough and adrenaline is high, if you haven't talked about it and everyone's not on the same page, things can run amok. So my message, and we're going to go over these great tools, but the bigger message is make sure that you've talked about it. And a lot of people say, oh, my kids know what to do. No, they don't. And if you come to a point where you're not able to talk for yourself or speak for yourself or your loved ones in the same situation, these will help them. And this is a way to be there for your loved ones. So today I want to go over some practical steps to protecting your wishes, and then, like I said, how to be there for your loved ones, and then some follow-up tips. So for all of you who raised your hand and said you have advanced directives, do you know exactly where they are right now? Would your family, if you passed out when you got home, would someone in your family know where they were? They're in an obvious place for 911 to find them when they get there. You know, and the other thing, and even for the 5 wishes that I have today, there would be no clear message for a paramedic in your home. If you were unconscious in your home, the 5 wishes is lovely, an advanced directive, they're great, and it's a legal statement of your wishes. But the green post form is they can look at it and they know these are orders from a medical provider. We put our license number and our signature on it, and they know what to do with it. It's black and white. So it's very medical, and they understand that. You know, regarding the experience of dying, we know what people want. The problem is there are a lot of discrepancies between what we want and what really happens. So Americans, if you survey them, which they have, they want to die at home. But in reality, less than 25% of us are able to do that. We want to die free from pain and in the company of loved ones. But in reality, it's often an unnecessarily painful experience and can be quite isolating too. And then we want to retain some control of the care that we receive using tools like this and having conversations that we're going to talk about. But only 20 to 30% of Americans have advanced directives on file. So you guys really are an elite bunch, because I think it was like 90 to 100% of you who have advanced directives, so that's great. So 2 of the solutions to kind of retain some control over the care that you receive are the forms that we're going to go over today. So the advanced directive, or 5 wishes, and then the PULSE, the practitioner orders for life-sustaining treatment. I like these because they're both in easy language. I think the 5 wishes, especially for some people who might have difficulty talking about it or feel intimidated by it, the 5 wishes addresses much more than just the medical aspects, and so I think it's just a nice tool to just talk about things a little more lightly and a little more in generalities. But it addresses the 5 wishes, who you would want to make to speak for you if you were no longer able to speak for yourself, if you were incapacitated, the kind of medical treatments that you would want or you wouldn't want, how comfortable you would want to be. In other words, some people may say, no, I'm willing to suffer a little bit if it'll help, and whereas other people, and it depends on what they've been through. You know, you can have people where your wishes change after you've gone through chemotherapy for 2 years. You know, things change. Even when I was a young ER nurse, I was dumb and young and cocky, and I said, no one ever do CPR on me. I want DNR tattooed across my chest. I never want to be in the ICU. I don't want to ever be on a respirator. And then I grew up and I had a baby, and I would do almost anything to be around. But I understand that might change over the years too. So the point is, again, it's not us doing our homework and filing it away and then we're done with it. It's revisiting it and kind of being aware. And then, so how comfortable you want to be. The 4th one is how you want people to treat you. And we'll go over that in details. And then what you would want your loved ones to know. So it's a nice chance to talk about some more personal things too. So if you want to look at the 5 wishes as we go through it, you're welcome to. It's in each of your packets. But wish 1 is the person you want to make healthcare decisions for you when you can't. And it allows you to name a person to act on your behalf. Legally, this is your durable power of attorney for healthcare, or also known as a healthcare proxy. And so that's an important one, and that's also important to make sure that that person is aware of that and that you at least have a conversation with them and hopefully your physician as well. And then wish number 2, the kind of medical treatment you want or don't want. So this is commonly known as a living will, and it expresses instructions for your caregiver, such as the need to take pain medication even if it makes you sleepy. It includes examples of life support, and then it provides space to put 3 different life support wishes for 3 different situations, which I think is nice because even me, I'm in my mid-30s, and you know, if I were hit by a car, God forbid, I would be willing to have some really intense treatment to get better from that. But if I had a long course of a chronic illness, and maybe I wouldn't be willing to have then go to the ICU after that, you know. And I appreciate that they acknowledge that there are different scenarios, you know. Some people, they would still want treatment if it were like an injury or a trauma or something like that. And then wish number 3, how comfortable you want to be. So it stresses that you want your pain managed, expresses your choices for type of comfort care, and you can cross out items based on your preferences or circle them. And number 4, how you want people to treat you. What others should keep in mind if you become seriously ill, whether you want to have people around you or your hand held when possible, if you want prayers said for you, ideas for your surroundings, such as pictures of loved ones or quilts or something that might be special to you if that were possible. And then 5, what you want your loved ones to know. So this encourages you to express matters of deep importance in an age where families often live apart. It allows you to offer love and forgiveness to those who have hurt you. And it asks for forgiveness for the times you have hurt others. And it communicates practical matters such as preferences for memorial or burial. So some tips at the end for signing it. You print your name and read the statement carefully, and you have to have 2 witnesses that you sign it in front of. But they don't have to read your wishes, they just have to read your signature. And then after you complete it, you should make a copy for your physician, your healthcare proxy, or your healthcare durable power of attorney, and any friends or family who want to have it, and then keep the original somewhere handy. They say like keep it in a top drawer, not filed away in the back somewhere. And then the pulse. So the pulse is much more what I refer to as a medical provider. This is a form that I reach for, not when I first meet a patient. When I see a new patient in our office, I don't bring it up the first visit, but if they mention something like, I'm really tired of going to the hospital. I have heart failure, and I've had to go 3 times in the last 3 months, and I don't want to do that anymore. Then we can talk about it, and I can ask, well, what if you were to become so sick that your heart were to stop beating? Would you want us to do CPR and try to resuscitate you? And usually when people are bringing that up, they don't want that. But we can have a nice conversation about it, but it needs to be with your medical provider. They will put in the state of New Jersey, it has to be a physician or an advanced practice nurse. And it needs to be with someone who has a relationship with you, who understands your medical history and understands your kind of psychosocial situation. But it's very simple, and I go through it line by line with my patients. Just name, what are our goals? If someone says, I don't want to go to the hospital, or, I'd be okay going to the hospital if I just needed some IV hydration or IV antibiotics, but I would generally want to avoid being in the ICU. I would not want to be hooked up to machines. Then we can lay that out, and I'm very detailed on it. And then when you fill out the pulse, you sign it together, and then I scan it into the medical record, and then the original stays with the person. And again, some are kind of easy to grab in the heat of the moment, because even our patients who are very aware of it, because Dr. Redling is boarded in hospice and palliative care. She's my collaborating physician. And I've worked in palliative care, and we're both pretty passionate about making sure we understand what a person would want, because It's a terrible feeling when we're trying to take care of someone and we're not sure. And when we've had the conversation with or without the form, I know what to do. But if you're not in New Jersey, or your doctor doesn't come to the hospital, or whatever, the best chance you have is to have the original with you and to make sure that your close family, spouse knows what your wishes say. You know, these are, one time even in the hospital, in the office, we were sending a patient across the street to the hospital. She was very ill. We rarely do that. And the doctor said, oh, you gave me the pulse from last time and I forgot. I said, don't worry, it takes, 60 seconds when we know what it's going to say. And we filled it out quickly so she was able to have that, so she had that peace of mind that her mom's wishes would be honored. It's very quick and easy to fill out. I gave you copies today on a green paper. It doesn't have to be on a green paper. It can be on any color. It's just they wanted a color to get a little attention. Like I used to work in California and I helped roll Pulse out there. Most of the states have it, but not all of them. And it was hot pink in California. It doesn't matter. It's just a color to kind of grab attention in a pile of papers. And so it addresses your goals, whether or not you'd be okay to go to the hospital. Like some patients say, no, I don't want to go. Like even patients on hospice, we address this because maybe they'd still want to go if we couldn't manage some of their symptoms at home. They'd be okay to go to the hospital for comfort measures that were, I've only ever actually that once or twice in my career. But anyway, and then whether or not you would want resuscitation, cardiopulmonary resuscitation, and whether or not you would want a feeding tube. So if you're no longer able to nourish yourself by mouth. And some people say, well, look, I'd be okay with a NG tube, just like a temporary trial. But if I'm not getting better or there's no real meaningful chance of recovery, I would never, the surgically placed PEG tubes, some people say, no, like, don't do that, but I would be okay temporarily with another tube to help nourish myself. So again, it's the advanced directive, and then the pulse form is a medical order set. So that's something that you can't fill out by yourself. The advanced directive you can. The green form is something that if you wanted it, if you have strong feelings that you do not want CPR and you know that, then you should fill it out. In our country, the default is to full ICU. And if you feel strongly that that's what you want, you don't really need to fill it out. It might be helpful because then no one will worry that we're unnecessarily torturing you and that we won't be too conflicted about it if we know that's what you wanted. But if you have strong feelings that you wouldn't want that, I do think it's good to fill it out. Oftentimes I tell people, this is the time. It's not when you got sick and you're already in the hospital. And plus, you guys already have advanced directives. So the pulse form, next time you go to your doctor, you could bring it and say, I have my advanced directives, they're here, and I want to fill this out that it's very parallel with my advanced directives. So it represents those wishes in a little more meaningful and structured way for the medical piece. So yeah, that's the main things about the pulsed and 5 wishes, and I am happy to take any questions and address any concerns any of you might have about these 2 forms. So, you had a question? Yes.
This is about a different thing.
Yes.
Okay.
Yes.
Do not resuscitate.
Yes.
Is there a form for that? And is it different in different states, or how does that
it
work?
is different. It is different in different states. Legally, the pulsed is equal. It just has more details. I have noticed at some facilities that maybe aren't up to speed, they still want the DNR form even though the pulsed is that. That's what it is. It's a medically actionable order set from a physician or an advanced practice nurse. And then in each state, the pulsed is different. Like they kind of have different acronyms in different states too. But this is the same thing as far as like someone saying this is my medical order. Just as if I were in the hospital and I wrote IV fluids, it's the same legally. It's the same weight. And so if someone didn't follow it, it's like they ignored the orders that we put in on a patient's chart.
Okay.
Yeah. Yes.
I have a question. With the HIPAA laws,
Yes.
are immediate family automatically able to know what the medical conditions are, or should you have a I don't know, medical surrogate form filled out by, legal medical surrogate form filled out maybe by an attorney.
Yes, I think that's smart to do. I mean, your spouse, if you have a spouse, would certainly have access. Your healthcare proxy would have access. And definitely I'm speaking as a medical provider and not an attorney, so please know that too. But that's another thing. We get hung up on these technicalities with this form. In the hospital, all we want to do is take really good care of this patient and honor their wishes. And so, I mean, I would never, if someone were unconscious in the ICU, say, well, I can't speak to you because they didn't sign a form, But I hear what you're saying, and it does get really messy. If you have kids and one lives far away and then one flies in and they start arguing about what's best or what they would want, it's nice to have said, she gets to make the decisions, and this is what I want, and I trust her to honor my wishes. And you can put that. You can put that on these forms. You can put that on the post. And you can definitely, I mean, every time with our registration form it says who we're allowed to share information with. But yeah, typically in complex medical situations at the end of their life, we know we have to talk to the family, and they may not have a form that specifically says that we're allowed to do so. Yeah. Did you have a question? Yes.
Can you suggest a practical way? Who should be notified if you both wish to be cremated and are an organ donor?
So the post addresses organ donation, and every patient who dies in the state of New Jersey, organ donation is notified. And so if you're a registered organ donor and we have it on a form, that should be protected. The advance directive addresses your wishes for cremation, which I think that's a good place to put it in. And then just making sure your family is aware too. Yeah. Yeah. Yes.
I have a question about the post. If you've got the post and it's at home or something,
Yes.
and you're in a car accident, I know that, as you say, the default is to sort of go all the way with the treatment.
Right.
So if they rush you to the hospital, and my understanding is that once you're in the EMT truck,
Right.
you're sort of set on that trajectory to
That's
have
true.
everything done.
That's true. And in the case of the trauma, that might be what you would want. You might have filled out the post form in the setting of, I just got diagnosed with this chronic or terminal illness, and I would not, as this progresses, I would not want to be resuscitated. But no one ever can guess if they're hit by a car. And you might want us to try to save your life at that point. And if you don't, that's when it gets really sticky, because that's why advanced directives are only followed about 50% of the time in our country, because you don't always have them. You might be on a cruise ship or something, and then you're in a different country, and then you don't have your post form, and you don't have your doctor, and you may not have your family and do what you wanted. So that's another reason why I say, like, having the conversation, because if you come in the hospital and you've lost your form, I filled it out, I did my homework, and I don't know where it is, and your family doesn't know where it is, or whatever happens, you don't have it. If they know what you wanted, then they would tell us, listen, she has a pulse form, she has advanced directives, she doesn't want this, this, and this, she's okay with this. We say, no problem, and we fill it out real quick and sign it with them and try to honor her wishes in that way. And that's another thing. I mean, people can have everything laid out and very clear about what they want, but sometimes families still tries to change it. So our job as medical providers is to help remind them of what their role is. It's not to say, if you're someone's healthcare proxy, oh, they can't speak for themselves, so now I speak for them. Your job is not that. Your job is to honor what they already said. Your job is to speak for them in the way that they would want you to speak for them. Legally they're allowed to say, well, I believe that they would have changed their mind because this. And it gets really sticky. I mean, it's really, I've been on ethics committees, and I've been tormented myself, feeling like we're not doing what this patient wanted, but There's the legal side of things as well, and we always want to be cautious and careful and make sure we're doing the right thing. And so it can get really, really sticky if it's not clear, and if you don't have someone to speak for you. So it's really important to have a healthcare proxy. I had a gentleman who I was called to do a consultation on, not for this. It was for like agitation and maybe some delirium. And I noticed that he was very sick, and I said, you know, do you have advance directives? And he said, no. And I said, well, would you like to talk about that? And he said, yes. And usually, if you can find the right moment with me for patients, it may be you for friends or family, sometimes if someone's really sick or they're having trouble, they're desperate to talk about it, but no one else wants to talk about it. And if you can find a little moment to say, well, have you talked about that? Do you want to talk about that? So anyways, this gentleman did. And we filled out advance directives for him, and he said, you know, I'm a risk man, and I would be willing to let you resuscitate me, but I wouldn't want to linger. And if I'm not getting better, you know, I would not want artificial feeding, you know, just let me go. And I said, okay. And I even kind of verified that he was cognitively intact. He told me his medications he was taking. I called his local pharmacist. I did a very detailed note. I filled out the PULSE form. I documented everything very well in my note. Well, he did code, and he did end up in the ICU. And I thought, oh, I'm so great. Thank goodness I did that with him, because now we can honor his wishes. However, since he didn't have a healthcare proxy, when he wasn't getting better and he was still intubated, the legal team got involved and said, no, we can't extubate him unless we have a family member, someone else to speak for him to say, yes, we agree with this. And I said, this is a bachelor, he's no kids, he said he has no family, he said he has some friends nearby, but otherwise he said he has nobody. So ethics committee was called, they're calling me like late at night talking about this, and they say, Sarah, we see your note, we see, it's very clear what he wanted, but legal is saying we need to have a next of kin. So social worker, everyone started working to try to scrounge and find a family member, and luckily some long lost nephew came forward who doesn't know him, but he could read the forms in my note, and he said it's very clear what he wanted, and he signed, and we were able to help him die peacefully and not send him to a long-term vet care setting. and I'm so thankful that the caseworkers were able to find, or I don't know if it was a social worker, I think it was a social worker who finally found this long-lost family member. But if it weren't for this guy being willing to come and look at the note and hear the story about his family member who he really didn't know, you know, I don't think we would have been able to honor his wishes. And I thought, okay, well, I'm going to learn from this, and I'm going to make sure that people have, when I fill out a PULSE with a patient, that we have next of kin. We have someone else who can speak on their behalf. So yeah, it's the medical side. You can think you're doing the right thing and being very ethical, but there's the legal side of things too. Yeah.
So, but for the health proxy, it
Yes.
doesn't have to be a family member, right?
No.
Okay.
It doesn't. If you've named someone your health, like he could have named, and I look back and I wish I would have had a name, his friend, and I didn't. In fact, he was so sick, he goes, it's on my record, I don't know, it's on the record. And I said, okay, and I let him sign it. But then they couldn't find these friends' numbers. And yeah, but you can name anybody you want.
Yeah, because sometimes a friend can be more objective and they will honor your wishes, whereas the family gets all emotionally involved. And
Yeah, and it might be good if you don't name your family to make sure they know that they're not. Like I have 4 sisters, and they're very different. You know, some are softies like me, and then my older sister Jessica, she's very tough. And I said, you could be my healthcare proxy. I'm going to tell you what I want, and I trust you to do it. You know, I probably really would just let my husband do it, but he's a real softie, especially for me. So that is just hard. It's hard with your next of kin. But if you've done this work and you've had these conversations, it takes so much more of the burden off them when things are difficult. Yeah. What other questions or I don't know. Have any of you had any experiences? Yes.
What did you say the percentage of people who have these forms filled out is?
20 to 30%.
And that's what of
Americans.
Americans, but what percentage of people who would say elderly people, for
Yeah.
lack of a better word?
Yeah. How many?
What percentage of elderly people have
I don't
the
know.
family?
I think that's a great question. It's probably more. Maybe that is mostly of the 20 to 30%. Maybe it mostly is elderly people.
Yeah.
Yeah. He asked me when we came in, well, what age? And I didn't give him a straight answer because, you know, I work with older adults. My average age in our practice is in the late 80s or early 90s. So 65 sounds so young to me, really, so young. Yeah, really.
Thank you.
And really, when people say, well, I'm 70, I mean, I'm like, you're young. Let's kind of keep you in check, you know, let's keep you healthy. But of course, you can have someone who's very ill and much younger, and I think it's good for anyone who has a chronic or terminal illness to think about these things. And oh yes, go ahead.
You asked for personal experiences.
Yeah.
Yeah, we've had a difficult one in my family. My parents are, well, my father will be 96 next month, and my mom for 5 years has been into heavy dementia.
Yes.
And 2 years bedridden, and now she doesn't know she's alive or anything. Well, in this winter, she was admitted for some kind of respiratory symptoms. And she refused when she was able to make a decision to have a DNR. So, and my father and then my sister are her proxies. And she's always said, I want to be kept alive because of you, Dad. I want to be with you, Dad.
Aww.
Which, yeah, is right, except that you get to the point where her situation went to the ethics committee because she was needing the peg. That's what it was. She had aspirated. She had an aspirational pneumonia. So she comes home, and you know, we had a DNR written over her bed because in the hospital she said, I don't want any more of this. I mean, she really got lucid for like 2 days. I mean, not extremely so, but enough to know who I was and to say, I don't want any more of this.
Okay.
So we struggled with the fact that if my mom knew what state she was in, that she wouldn't want to be kept alive like this.
Right.
This is not what she ever envisioned.
Right.
And she's mainly saw it as an emergency kind of situation.
Right.
So I guess the question in my own conversation would be, okay, well, you're hit by a car on the street, or you have dementia for a couple of years. Where are you at in each of those situations?
Right.
And to make sure that that's clear in the documents.
Yes, and I've actually written that. I had a young lady in her, I don't know, I think she was in her early 70s, and she was new to our practice. And she said, I want that pulse. I've heard about the pulse from her. I want the pulse. I said, well, you're young and healthy, so I will fill it out with you with a caveat that if we're talking about some kind of acute trauma or something like that, that you would be okay if we treated you for that. And that brings up a great point, and it's another reason why I love 5 Wishes, because it kind of helps you brainstorm about different scenarios. Like, I'll be okay, like she was thinking, if I just had an illness or if I needed to battle cancer or something, like she was willing to do that. But maybe it didn't occur to her, or no one asked her, well, what if you had advanced Alzheimer's? And you were no longer able to nourish yourself by mouth, and you weren't able to walk or talk. Would you want us to do all that at that point? And she probably would have said no, and that's why it's okay. She had healthcare proxies because she trusted you guys to say what she would want for her. And that's one of those situations where you're so glad they have a healthcare proxy. They say, no, I think she would change your mind now. And you're like, okay, I agree. I mean, you know, we could get into long discussions about quality of life, but advanced dementia is really, really hard. Really hard, yeah. I think that's a great point. Very good, yeah. No, it's welcome. Any other questions or thoughts? Yes.
My father died a couple of years ago, and so my mom, you know, they they are, as Reverend Pop said, they're very organized, very practical.
Yes.
They've got everything laid out in notebooks and stuff. So, but my mom was saying the other day, she said, you know, I guess it's like the pulse. She says, I have that somewhere around, and I haven't signed it because I'm still waiting. I'm thinking maybe in an emergency I'll sign it. I'm thinking, oh, great. And is there a place, I mean, I know you can't say in every house but is it the kind of thing you should put on the refrigerator?
Yeah. If it's like distressing to people or they like don't want that around, then even like kind of by their bedside table.
Okay.
But they would know to look on a refrigerator or somewhere near the bed for it. They would know that.
Okay.
You know,
okay.
And for our patients, I mean, so I work for a Barnabas office, you know, but I mean, if someone called me and said we're going to the ER, I have printed their pulse out and hand delivered it to the ER. They're on their way because I know that it's like chaotic in those moments in the emergency. But tell her, Mom, the time is now. Especially if she said, no, I would not want to be resuscitated. I mean, that's the whole other really big conversation I have with my patients is, do you understand what that means? Because it's not like it is on television. I think the success rate of CPR on television is like 95% or something. It's very, very high. And in reality, especially with advanced illness, it's very, very low. And people don't realize that. We're not keeping you alive, we're bringing you back to life when we're resuscitating someone. I mean, you know, if you're very ill or very frail, it's not, I mean, and I will admit that I'm biased. I am a little biased. I fully support it when people say, no, I'm in the ICU, I want everything. I just want to make sure they understand what that really looks like, because most of us haven't been in the ICU. We don't really know what we're talking about when we sign ourselves up for that. You don't really know unless you've been in ICU. And I had a lady that said, no, I wouldn't want the compressions, and no, I don't want to be hooked to a machine. And then her daughter said, well, Mom, that's how they bring you back to life. She goes, oh yeah, I want you to bring me back to life. I'm like, but that is how we do it. That's how we get there. And it's intense, you know. Young, healthy bodies can handle it, and they can survive sometimes, and we're lucky, and they get to the right place at the right time. But yeah, it's not like that with advanced disease. Yes?
Also, when you do come back to life, in those kinds of circumstances, it's not the life you knew.
That's right. That's right. I mean, even for that, you're so right. And I mean, of course, if there's a long downtime, you can have anoxic brain injuries and really never be yourself again. But even for seniors who are admitted to the hospital for a few days, you can have someone who was previously ambulatory with a walker and continent, and then even just a few days in the hospital, they can't walk because they haven't been getting up enough. They're malnourished a little bit, and so yeah, it's a rapid decline. I mean, Dr. Redley and I, good morning, turn on the lights, don't let anyone get delirium, get them in their chair. We feed our patients some mornings when we're rounding because it's all like nice basic care just to try to maintain that level of function. But yeah, going through an ICU, I mean, it can take, you know, it can take a long time for people to recover. So yeah, you're right. Any other questions? Yes.
So if you make changes on the advance directive, as you said, that
yes.
you know can be periodically updated, do you have to get it notarized each time, or
neither of these need to be notarized,
or just witnessed?
Oh, yeah, you would want it witnessed again.
Okay.
I mean, the pulse form would take 2 seconds, and you would just change it again with the provider's signature. But that is another reason why I like this, because they don't have to be notarized. But yeah, I mean, I am coming to you as a medical provider, not an attorney. They would probably say, oh yes, it needs to be re-signed. My thing is, my opinion is that if you had talked about it, then that's good. And if your doctor knows, that's good. And it should be looked at periodically. Because if you come in with a 10-year-old pulse and a complex medical scenario, it's going to carry much less weight than one that was signed in the last year or two or few weeks or whatever, especially if the medical picture had changed. So it is good to revisit them, and that's a great tip. Yes?
I was reading just yesterday about a person, they were talking about a person who had Alzheimer's and they were behaving very badly.
Uh-huh.
And so the doctor just gave them more sedative type drugs. But it turned out the person was in pain, but they couldn't express it.
Right.
So another doctor who was a gerontologist, is that the right word?
A geriatrician.
Geriatrician,
Yeah.
okay. You know, understood that this patient might be in pain, so they gave them pain medication, and they acted much better and actually were talking.
That's right.
So, can you put that in this form?
No. I mean, I could write a note that, you know, FYI, medical providers, past medical history of dementia. You could tell, yeah, you could tell. I mean, I would be willing to write that in because you bring up a great point. I specialize. I know that. We go to consultations for this. They're confused. They're combative. When we're giving them a medication that's making them that way, or we're not treating their urinary tract infection or their pneumonia, or they just want to get out of their bed. They want to sit in a chair and they're fine. So we know that in dementia, if someone's agitated, the last thing that we do is we do use medications, but it's after checking for anything else that could be causing a sudden change in their personality, because that's not really normal. And the other thing is when people have dementia are sick, they have a much higher risk of becoming delirious. So that's like that like, Mom, what's wrong? They're like, they're not even answering you. That's kind of like a hypoactive delirium. Or when they're like, there are spiders on the wall. That's not normal even for dementia to be hallucinating, for Alzheimer's dementia, to be hallucinating and very agitated and ripping their clothes off and not knowing what things are. I mean, that's delirium, and people don't realize that sometimes. And if you just treat them with a sedative, and you're like really ignoring maybe something that could be life-threatening. So there's yeah, I guess on the post, if someone brought that up and it's such a valid point, you could put past medical history of dementia, you know, something like that, just so they know, because that instantly is like it's an entirely different scenario when you're treating someone like that.
So if they're agitated, there may be a good reason they're agitated, but they just can't tell you.
Usually there is.
Right.
So that's a lot of what we do is educating the caretakers and you know, caregivers and family members about what this behavior means. There usually is some meaning behind it. You know, we do a virtual dementia tour every year at the hospital with the medical residents, and we did it this year also with nursing staff. And it's really fascinating. Like even one of the physicians who went through it, she's a wonderful, compassionate, amazing physician, and she was really frustrated, and she was like, oh, I don't know what to do. And you see very quickly, within a few minutes, some of the behaviors that sometimes we see in dementia with a, you know, highly educated, young, healthy, but we minimize their ability to feel. Like we put gloves on, we do goggles, and then make it hard to hear, and then we rattle off all these instructions, like in the hospital. And then we're going to do your CT scan, we're going to do your blood work, blah, 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 you know. And they can't hear and they can't see and they're confused, and then they're kind of like, you know, people will come up to that really have dementia and say, what am I supposed to do? And it's like they need help. They just need someone to say, you're okay, we're going to sit here and just like give one instruction at a time, make sure they can hear and see you, write it down if you need to. But you start to see some of these bizarre behaviors from young, healthy people that are going through this tour, and then you realize there's meaning behind all those kind of like agitation or just kind of bizarre things. People kind of start like they'll kind of walk over the table where we gave them direction, they'll just kind of start moving stuff because they know they're supposed to be doing something, but they didn't understand exactly what, so they just look really confused. And we see that all the time. We see that all the time, and it's very powerful to go through it because you instantly, even me, I consider myself to be very patient and very empathetic, but when I went through the tour, I became more so, much more so. Because it's really hard. It's hard to have dementia. Yeah, and it's hard to be the caregivers too. Yeah. Any other questions that anyone has for me? No? Well, I really appreciate you all being here. And you have the packets. And you're welcome to ever contact me if there's something that you thought of or a concern that you have. I'm happy to talk with you one-on-one. So my contact is in there as well. All right, thank you so much. Thank you.
just also want to tie that into, thank you for your great presentation. At the health department, we offer a file of life, which if you're not ready to have the full-blown conversation, you can start with putting this on your refrigerator. It's magnetized. You can put it on your refrigerator, and in it, it has all of you write it in pencil, because everything changes every year or every couple of years. You write it in pencil, and you fill in who your medical practitioner is, who's your emergency point of contact. You'd write down that you have a living will. This would be taken by your EMS, by the Maplewood Health Fire Department or the First Aid Squad, and they would pull this off of your refrigerator and know that you have it because you'd have this sticker right on your door. You could also then give this smaller one to your healthcare proxy or your next of kin or whoever you trust with this information, whether that be your spouse, your sibling, a neighbor, so that they would have it. And then if they get that phone call in the middle of the night saying, your mom, your dad is in the hospital, what medications, do you know what medications they would want? Do you know what illnesses they have? They would know because they would carry this in their wallet, or you could carry in your wallet and we'll give you extras. So if you're interested, I have a couple here, or you could call the health department for more information. Thank you.
Yeah, thank you.